here. So welcome to Mips Tips. Today is an open office hours. If you've attended with us before, you're used to us having an actual topic on hand that we present slides with and go over the topic in depth with you. But we thought with this being our last year being contracted to support our SIRS clinics for Mips, that we want to start, kind of really answering your deeper questions and getting you guys more comfortable with finding some of the data on your own if we're not here next year to help supporting you. So that's kind of what this is geared towards. So first I want to start with, my name is Miranda and I work with Mountain Pacific, and I want to thank you all for spending time with us today. Mips Tips webinars are a collaborative effort between the three organizations named on the slide, with the goal of providing clinics and clinicians timely information on the quality payment program and to give you a chance to ask your questions related to this program. Between Mountain Pacific, Comagine Health, we support a variety of states, which you can see here on the slide. So we kind of like to do this together so that we have more of a collaborative take on it. So a few housekeeping items before we get started. Please take a moment to locate your chat feature in this webinar platform. Links to the resources from the presenters should be shared. We don't really have that many links for this one, but if we do find something while we're having the conversation, one of our technical assistance contractors can pop it into chat. So that way you'll be able to copy it and use it at a later date. This webinar is being recorded. The resource link shared through chat and the link of the recorded webinar and a copy of the slides will be shared with attendees and registrants in an email following the webinar. If you would like to download a copy of the slides, you can follow along with today's session and take notes. We usually put a link in the chat, but I'm not sure that we actually have that today. The slide deck and recording will also be available on the Comagine Health and Mountain Pacific websites following this event. So if you can find the slide deck and recordings there from our previous webinars, along with a lot of valuable QPP resources that we have. Okay, so to start with, we just want to give you a little bit of information about us. So Comagine Health and Mountain Pacific, these are where you can find our websites, where you can find the resources that we have put on there, and also direct emails to each one of our companies. So in case you didn't know specifically which state you're dealing with or who you needed to speak to, you can reach out to either one of us and we'll make sure that we get you in contact with the correct person. So just to go from the top, as I said, I'm Miranda and I represent Alaska and I'm with Mountain Pacific. I also take care of Hawaii. In Idaho, we have London Manor Peterson and she's with Comagine. And in Montana, we have Allison Bruner, she's with Mountain Pacific. Nevada, we have Aaron Hubbard and he's also with Comagine. And in Oregon, we have Seema Rather, who's with Comagine. Utah, we have Perrin Andrel, and he's with Comagine, and in Washington is Jeff Sabotka, and he's with Comagine as well. Sorry if I just butchered your last name there. And then Wyoming, we have Sharon Phelps, who's also a regional account manager, and she's with Mountain Pacific. So we want to kind of briefly go over with you right now where to find resources. So if we're not readily available, or like I said previously, our contract is coming to an end, and if there's no extension, we unfortunately won't be with you for the 2022 Mips year. So we want to kind of direct you on where to find resources and where we really go to look for the new stuff and find out what's out there. So first of all, this website, qpp.cms.gov, is the be-all end-all for where CMS is going to put information out. So if you guys have trafficked this website a lot, you'll have noticed that last year during the COVID pandemic, there was a lot of updates about Mips that were actually on this landing page where you could find out kind of real time what's going on with the program. But another place we like to go is under resources here. And then you have both the resource library and you have the webinar library. So the nice thing about this is CMS does a lot of actual webinars on some of the topics, because some people can read through it and completely understand what's going on. Other people are more visual in learning, like this Mips Tips. And so they actually like to kind of be able to watch what's happening and take it in that way. So I do encourage you to look at both the resource library and the webinar library if you have questions about any kind of topics. As you can see, both of their search features are very similar. You can break it down to performance year, the track, and even the specific category, or you can just search by simple terms. I will tell you that the search mechanism for this is not exactly all encompassing. You'll have to be kind of creative if you're looking for a specific topic. Like if you put in QRDA3, it might pull up some resources, or if you put in EHR reporting, it might pull up others. So that's not really an all-inclusive search function. So just keep that in mind when you're using the website, that you might have to be a little creative to find the actual document resources that you're looking for. And then next, this is on that main page as well. If you just have any kind of simple questions, once you look at the Mips, you can see that they have it broken down pretty well and organized within the website, where you're not having to search all over for everything. An important thing to note is the exception applications. And that is where you're going to find the extreme and uncontrollable circumstances application for 2021, and also the promoting interoperability exception application, which we just got notice yesterday is live now in the QPP portal. Okay, so now we're going to move on to the question part of the presentation. I would like to have some of the other panel hop on off of mute, if you wouldn't mind. With me in presenter mode, I can't exactly look at the agenda. So if somebody wants to prompt some of the questions, or if we have any live questions right now, feel free to come off of mute and go ahead and ask.
So Miranda, this is London. And one of the questions that we had gotten when people registered, which you might be able to help us answer, is why should I report if I don't have to? We've heard a lot about these exception applications, and if they're giving kind of a free ride. I mean, can you talk to us a little bit about why maybe we should be reporting Mips?
Sure. So in all intents and purposes, unfortunately, to some people's view, Mips is not going away. And it unfortunately is also only going to be getting a little bit more difficult. This is the last year of the transition year. And when it comes to 2022, there's already talk of implementing MVP pathways. There's the APP that's new this year. And also when it comes to reaching a neutral score, they're talking about, the 50-50. 50 you're going to be above the score and 50 you're going to be below. So it's not a preset point. So the thing is, if you don't report now, it's not going away. You're still going to be faced with that negative 9% reimbursement rate if you choose not to participate in the program. There is exceptions, because of the pandemic that has been going on, but that doesn't necessarily mean that your clinic actually meets the qualifications for it, because CMS can see what you're billing, to Medicare, and see if there's been changes in volumes of your patient load and what's coming through to them. So, if you claim a COVID exception saying that, you had disruptions to your business, but there's not really proof, then you could potentially set yourself up for an audit. So it's always good to report if you're required. If you're not required to report, also the scores are published on Physicians Compare. So when you report, the higher scores are, not that there's much traffic at Physicians Compare at this point in time, but it is a score that's out there. And then if you're not required to report, the idea is, there's always a potential of you becoming eligible to report, or another program like this coming around. So if you're capable of it and you have the time, it's something worthwhile to, and also the point is to help improve quality within your own practice.
Yeah, thank you for that. I think one thing to note, Miranda, you showed us where to go on the website. There are a couple of different hardship exceptions, and the applications for those are actually open right now. So you can click into the website and determine for yourselves. There's the promoting interoperability hardship exception. You as a small practice might qualify for that, which means you wouldn't have to report the promoting interoperability. Those points would get reallocated. And then, like Miranda mentioned, there's the COVID hardship exception. And if you truly are seeing, that you're having difficulty maybe seeing patients, or, the workflow just isn't happening in your clinic like normal, that's available to you as well. But like Miranda said, you would still, eventually you'll still need to be reporting. So we think it's good practice to stay in the habit, but definitely research those for yourselves. I was curious, since we only have a few of us on the line, are you planning on reporting Mips data for 2021? Okay, great. I made the assumption, if you were here, that most of you were planning on reporting, and so that's what you're here to learn about. Great, thanks for that. I'll share those results. 76% are. There's nobody that's not. Basically, if you didn't answer the question, it doesn't apply to you. Let's see, what else do we have? So
looks like we had another question about what's the best way to increase my Mips score. So
yeah.
I can take that one. It's always good to build off your previous year. You want to stay on top of your quality measures because they do change from year to year. From 2020 to 2021, I believe 113 quality measures had changes to them. Now, a lot of them had, including telehealth, because with the pandemic, it actually pushed us more into telehealth industry than previously. CMS had allowed for billing. So that was a lot of the changes, but there were also, was it 11 measures that were removed? Correct me if I'm wrong. I believe it's 11 measures were removed from quality and 8 of those were claims measures. So people that actually bill with claims data submissions as opposed to through an EHR, it just got more difficult, for you to report. So it's always important, to look at your quality category and to make sure that your measures are up to date. And if you're reporting the same measures from year to year, it's important to look back and see, were there situations that people were missed, that could have increased your score, or could you maybe set up a better situation where, some of the patients that should be in your numerator, and are in your denominator don't kind of fall through the cracks. So that's always a good thing to look at as well. London, do you have anything to add with that?
Let's see. I guess my best advice is just to look at your measures, right? And there's a lot of topped out measures and they stop at a certain amount of points. And sometimes those are the only options that you have. But if you have other options of other measures you could report that aren't topped out, that's a great way to look at improving your score, because those topped out measures stop at 7 points, but you have a measure potential of scoring up to 10 points.
I see in chat that we just had something from Heather that just said, I wish running a COVID vaccine clinic counted as an improvement activity. It's been all consuming since January, which we can all, completely understand that. I do want to point out that they did for 2021 create some parameters around, let me think of the wording here for this, nominating and applying new improvement activities. That might be something to look into, nominating, because the thing is, it's not so much going to help this year, obviously, but potentially creating one that is around a pandemic vaccination event. Obviously it's not something that people can use year to year, but we're already talking about boosters for COVID that was happening, that have already had the vaccine out. They're already talking about a booster, so we can see that this is going to continue on. So it makes sense that if you had a well thought out improvement activity that revolved around pandemic vaccinations, that is something that you could think about and actually suggest to CMS to adopt as an improvement activity.
Yeah, I know last year they had opened up an improvement activity for being involved in the COVID clinical trials, but that also required a lot of data submission for that clinical trial. It wasn't a pretty straightforward improvement activity like you're suggesting, Heather, and I do think that would be a really great idea. I see that another question came in about, should we report all measures? And I think maybe Perrin would be able to address this for us. It kind of fits along with what I think you were going to talk about, Perrin, and that's like, how do you determine what measures to report?
Yeah, sure, I can talk about that. And I'm assuming, Kimberly, you mean quality measures. So we'll just talk about quality measures. If there's other questions about measure submission, we can address that as well. So when you're determining quality measures, the best thing that I would recommend is look into specialty measure set, because they have grouped those quality measures kind of toward the specialty measures that or the measure sets that you typically work on within your practice setting. So if you have family practice or you're in cardiology or whatever happens to be, they've kind of pulled those measures out and said, hey, these are the ones that typically you might use within that specialty measure. So I would take a look at that first. If there isn't a specialty measure set for you, the next thing I would do is look at the measures that you're reporting now. Look at the things that you're doing within your clinic, and then search the quality measures to see if there's any that match up with your current process and what you're doing now. Lots of times, you go into a specialty measure set and you say, well, I'm doing 2 or 3 of these, but I'm not doing all of them. And so sometimes it's a little tricky to be able to get enough of your quality measures, the 6 that you are required to report. Sometimes it's a little tricky to get all the measures, the points you potentially need to earn to boost your score. So another thing I've found helpful is lots of times registries have a lot of good information and ways that they can help boost your score on quality measures. So if you are associated with a registry, or even if you're not, you can check with the registry and just let them know what you're doing, and they may be able to help you with looking at measures that you may not have thought of, because they deal with a lot of practices, and so they have a lot of experience with a number of different practices, and so they may be able to help you with those gaining or looking at quality measures that may be beneficial to your practice.
Thank you, Perrin. Did that answer your question about the quality measures, Kimberly? Once again, there's specialty measure sets, or to report for Mips, you need to choose 6 measures that you can report on. That's the minimum requirement. Okay,
So
great.
it looks like we got another question in chat from Joe, and it said, would there be an issue with applying for both exceptions? So there's not an issue with that, but there's a difference. So the promoting operability exception is offered, and strictly because you guys are predominantly small practices, so that means 15 or fewer NPIs associated with the TIN, you are automatically able to apply for the hardship exception for, the exception for the promoting operability category, which means those points then go to your quality. So it's redistributed. The extreme and uncontrollable circumstances, that's kind of a different thing. Like they've already, Texas has already been designated uncontrollable circumstances area. So that application or that automatic reweighting will apply to providers in that area because of a natural disaster. The COVID exception for the EUC is actually new. That's something that came about in 2019 and then 2020, and now they're pulling it along to 2021 as well. Now with that application, you do have to justify why you're filling it out. You have to, there's a blurb section where when you fill it out, you have to say, the reasons why you feel you're entitled to the exception. And, those could vary, those can vary greatly. So it's completely up to your thought pattern as a practice. If you guys have questions about that, they can speak to you more, in general. But in that application, you have the option of picking a specific category, a couple categories, or all categories. So, since improvement activities and promoting operability are only 90-day windows, you still have plenty of time to get those done for the rest of the year. But let's say at the beginning of the year, you really were hampered because, like maybe previously you were doing a lot of COVID vaccines at your clinic, but you weren't really seeing your regular patients. Or maybe you closed the clinic and you guys were helping with vaccine drives someplace as opposed to actually doing regular office visits. That's going to kind of hinder your data for quality. So maybe you could apply for the quality program, but still the quality category, but still participate in the improvement activities and the promoting operability. So there's a different variety that you can do for that. But the long or short answer is no, you can apply for both. But if you apply for the PI exception under the EUC, then you're basically kind of just double applying if you also get the PI exception.
Right. And I realized as we're talking, Miranda, that we're talking about how you can exclude out or get exceptions for certain categories, but how do you know if you're eligible to begin with, right? I think one of the questions we had in registration was, how many Medicare patients do I need to see? So maybe we could address just eligibility.
Sure. So for eligibility, there's specific practitioner types that were assigned, that were eligible for Mips. And then they added, what was it, 7 more, I believe, in 2019. But basically, there's a low volume threshold. And that's come into play a lot right now for, what happened with COVID. So the low volume threshold is actually 3 benchmarks, basically. So if your clinic, if you're a clinician and you bill more than $90,000 in allowable Medicare Part B charges, and you see more than 200 Medicare Part B patients, and they have to be individual. You can't see 1, 3, or 4 times, and that counts. It's individual Medicare Part B patients. And then if you provide 200 or more covered Medicare Part B services, so that can be the same patient maybe 4 times throughout the year, that counts as 4. And if you meet all 3 of those qualifiers and you're a specific clinician type, then you are required to report Mips. So where I said that kind of was interesting is with the smaller clinics, a lot of times they just kind of ride that line of eligibility where, their practice just kind of barely makes it or, is a little over. But with COVID, we did see a drop in eligible clinicians because of, their practice is slowing down during, 2019 and 2020, because our eligibility years are actually lagging in the participation year. So the first run for eligibility for 2020 is October 1st of 2019 to September 30th of 2020. And then October 1st, or is it 31st? Sorry, October 1st of 2020 to the end of September 2021. So everything that is showing the eligibility for 2021 actually has already happened. So we're still kind of in that lag of the slower businesses. And so some people have dropped off, and unfortunately, businesses are picking back up. And so there's a potential that these people that were not eligible in 2021 due to the pandemic will now pop back up on the radar for 2022 and be required to report again.
Yeah, and something I wanted to point out is you can see right here on the screen that box that says check participation status on that qpp.cms.gov website. You can check your participation status by signing in with your NPI, and it'll let you know if you're individually eligible. It'll also let you know if the TIN is group eligible. Now, being group eligible does not mean that you are required to report. You need to have that individually eligible to be required to report. You can report as a group if you're all Mips eligible, but it's a nice thing to know that they call it, you're an eligible clinician. It's a nice way of saying you're required. So I just want to remind you that individually eligible means you are required. Group eligible means you can report, but you won't get the penalty if you don't. I hope that makes sense. So there's often a lot of questions about your EHR and how they handle tracking measures. I was hoping, Erin, you wouldn't mind coming on and talking to us about that a little bit.
Yeah, so your EHR is a huge component of the Mips program, like many of you already know. And so as I work with the physician offices here in Nevada, there's a couple things that I always recommend that you do. One, it is so important to understand what the workflow is behind the measures. And so, I can't tell you how many times I've gone into a physician office and I take, for example, the tobacco screening measure. And I said, well, how many patients do you do a tobacco screening on? And I said, we do every single patient. And then as we pull the data, we find out, they are not at 100%, it's much less. And then as we go in, we find out that, we're not clicking all the correct buttons. So for example, the smoking cessation example, if somebody does use tobacco, there might be a box that you have to click that says, we gave them information about stop quitting. And so they have to click that box for it to count. Same with BMI. If somebody has a high BMI, there might be a box that you have to click that you say you recommend a diet and exercise. And so understanding the workflow. And so if you've not done this already, I would recommend maybe scheduling an appointment with your EHR vendor, just so you understand which boxes need to be clicked for the quality measures that you select. And that will help you hopefully improve your quality metrics. And then for the promoting interoperability side, kind of the same thing, making sure that you understand every button, every box that needs clicked in order for you to get those measures. If you're looking to close a referral loop, what does that look like in your EHR? If you're looking to do any of those measures, how do you select the correct buttons to help you get credit? So understanding that workflow is so important as you use your EHR for the Mips program.
Yeah, thank you, Erin. Appreciate that. So Jody, I see your question in chat about the cost category. If you did the EUC, I'm assuming the EUC application for all 4 categories, and you're wondering if you're going to see your feedback. I don't actually know the answer to that. Sharon, do you happen to know, are they still going to get feedback if they exempted out for 2020?
That's a great question. And interestingly, Jody, 14 minutes before this meeting started, we got a notification from CMS that they are reweighting the cost category of 15% for every single Mips clinician to 0 for 2020. And that pertains directly to your question. What CMS is saying is they do not believe they can reliably calculate the scores for the cost measure based on a decrease in service utilization in 2020 because of COVID, and because the effect that COVID had on how they calculate the cost measures, that it really changed the risk adjustment because of hospitalized patients where COVID had such a high severity. And the number of clinicians who met the case minimum for those cost measures was much lower than normal, again, due to COVID. So good news, in 2020, nobody gets a cost weight anywhere. So I think what that means is that nobody will get a report on the cost data because they do not believe it's accurate because of the impact of COVID. Now, perhaps they may give us just some informational stuff. They have not indicated whether they will do that, but typically when they do something like that, it's because they don't have a comfort level in the data. So I would be surprised if they release anything. So that's brand new news.
So I'm curious of our audience, which of the Mips categories cause you the most trouble? Which one do you struggle getting the data with, or have a hard time getting your score up on? It's a mix. Quality and promoting interoperability. I do see some improvement activities. Answers are still coming in. I'll give it a second. Got some cost in there too. Great. So it looks like we should have questions across the board, right? We've got people that are struggling with their quality. Somebody is struggling with improvement activities. Be happy to talk to you about improvement activities, promoting interoperability. I know a lot of times closing those referral loops are a problem. If you want to, pop into chat what it is that you're struggling with, maybe we can speak directly to that. Okay.
Oh, I see a question just came in about direct addresses. This is in Sharon's wheelhouse. Sharon, you want to pop back on?
Thanks, Miranda. So let's see. Any genius wisdom on direct address access? If you dig deep into one of the rules, it might be either the information blocking or the 21st Century Cures Act. It's one of those. It's been a while since I've looked at it, so I apologize. I don't know it off the top of my head. There is language that requires the direct addresses be put into the NPI attached with a person's NPI number in the NPPES system, where everybody gets their NPIs. However, that was delayed. I have not seen any out there. I have sporadically checked. And the last I heard, there was difficulties from a technical perspective of actually getting those in there. So in the long view, in the future, you should be able to look people up by name and get their direct address where you would get the NPI number, which is actually public information. I don't think that's available today. I
Sharon,
encourage
can you explain to us what direct address is? There was a question in chat.
I can. So what direct address is it is a secure email address. So if you, as my physician, if you email me my patient information to my Gmail account, that is not a secure email process. That email address, something could happen and people could get access to my protected health information. But there is a set of email addresses. If you go through specific internet service providers, they're called HISPs, Health Internet Service Providers. And they have a secure channel that those emails travel through. So if you have a direct address, it's a health secure email address, and you can email documents back and forth from one provider to another. Now, most of the time, this has been set up to be kind of in the background, in the guts of your EHR system, so that your EHR can email to the hospital's EHR, or the hospital's EHR can email to your EHR, and it's built deep within that system. But there are some people that you can use that secure email just like you would your Gmail or Yahoo or whatever regular email account, but you can only email back and forth to secure accounts. You can't email to Gmail. It has to be a secure account. So it works like a little mini health information exchange. A lot of times you have to talk to the IT folks for a given facility or whoever does the EHR support for a clinic to get your hands on that address. So if you're having difficulties, like with your hospital, I would ask to speak to medical records or ask to speak to like a clinical IT person, and they're the ones who probably can give you that address. I think people have been struggling with this for some time. There's not a national directory for those yet. It's been recognized as a problem. They're working towards it, but I don't think it's out there yet.
So Denise had a follow-up question. How can we improve that PI measure without access to those direct addresses?
That's a great question. I would encourage you to talk with the Health Information Exchange in your state to see what options you have with them. And sometimes they have those direct email addresses as well. And sometimes your state health department may have those. I know there's at least one state that will provide a direct email address to you if you've not gotten it from somewhere else. Now, where the functionality fits with your EHR, I'm not sure. That may be the problem. That's another place you can look and talk to is your EHR, your support folks, because they may be able to help you.
Thank you. I see, Heather, that you had a question about the determination period, and I was hoping I could help clarify that for you. So when you are looking up in when you're looking up in the Mips, lookup tool, and you are seeing your clinicians associated with your TIN, if you see a clinician with your TIN and in the first determination period, it says they are not Mips eligible, they will not become Mips eligible in the second determination period. There is a small window that can happen where if in that first determination period, you don't see your clinician attached with your TIN, but they've started. It's usually a new provider that started a new TIN. It is possible for that new provider who was not previously showing up to show up in the second determination period. So those would be the only providers that you would want to keep an eye on, is if in the first determination period, they do not show up associated with your TIN. The possibility of them showing up in the second determination period is there. I hope that clarified that question for you. Okay, so here's another PI question. For promoting interoperability, do we have to participate in registries, and how do you get connected to registries in your area? Actually, I think, Erin, you might have been the one that said you were going to talk to this particular issue.
I was, and I saw that question come in, and I was going to pull a little file for her to look at. And so for that one, for the registries, a couple of things to keep in mind. One is to participate in the registry, you want to be connected to them. What does that mean? That means you have a bidirectional connection, EHR, to the registry. That is one of them. Couple of things to keep in mind when you do that. There is a cost associated with those connections. So talk to a registry. Jody just said they use a national registry. The other thing too, when they talk about some of those things, it depends on which state you live in. Every state is a little bit different, especially when we talk about immunization registries, syndromic surveillance, some of those. Every state is different. And so look to those organizations within your state to see how you can get connected with them. For example, I know from a little bit of work I'm doing in Washington, connecting their EHRs to their PDMP is something that is going really well within that state. And so I think that's all that comes to my mind off the top of my head.
Great. Thank you, Erin.
Does that answer your question? Is it a dare?
Looks like Heather said that their EHR actually had registry suggestions for them to use as well. I mean, so that's a good resource to tap, because, you call your EHR, talk with their customer service, and just kind of, get some assistance to, explain to them what you're trying to do and see if they can help come at something, from the background that you might not have thought about, because a lot of the EHRs obviously aren't, state specific. They're, nationwide. So they have a bit more of reach sometimes than some of the HIEs that we have, per state. So that's definitely a good suggestion.
If they are connected to your EHR already, that is wonderful, because like I mentioned, some of these registries, there is a cost associated with it to get your EHR connected to it. And so that using your EHR, that's great.
So Denise has a question about APM. Is she correct in her understanding that within a certain time frame, we will all be encouraged to move into an APM, and the sooner we are able to do so, there's an incentive to do so sooner? Who wants to take an APM question? Because you're right, the quality payment program, you've got two options. You can report MIPS or you can report advanced payment models. Ooh, I see we have Dave Cook on the line.
This is a topic I love. I would be glad to address that one, Denise. So with APMs, the hope, we're in a journey in healthcare towards value-based medicine, and APM stands for Alternative Payment Models. And then probably the most widely known example of APMs are ACOs, which stand for Accountable Care Organizations. And in every state, there's different APMs and ACOs, Medicare ACOs. And so there's different options available to folks and to different clinics and healthcare systems. And it really is an individualized question about what options do we have available and what would meet our criteria as a clinic. And when you're looking at different ACOs and APMs, you want to look at how far advanced they are. Are they meeting shared savings goals with Medicare? And they have these agreements with Medicare or different targets they're trying to meet. You want to, the incentives within the APM are achievable if they are hitting these shared savings targets. So you really want to keep an eye on that. And then also just, does their philosophy of this APM match ours and so forth are some of the things you want to look at. Now, if you're in an APM, if you're in an advanced APM, which is an APM that has downside risk, you're fully invested in it, both sides, and is one of Medicare's advanced APMs, you get a 5% bonus on your Medicare claims in addition to the APM. So Medicare really is trying to encourage folks towards the APMs in the long run if it works. I have not heard about a mandate for APMs, and I think that's a little bit down the road probably if it does happen, because in some cases the availability is not there yet. So in that respects, I think it is important that clinics are looking at what options we have and evaluating APMs and putting processes in place like chronic care management processes, annual wellness visit processes, and some of these processes that risk scoring that ACOs look at so closely. I think it's important to have that on your radar and be ready for those kind of things in your clinic. But as far as any mandates, I haven't heard of any mandates coming. But so anyway, hopefully that gives you a little background, and we can talk offline also if you want to do a deeper dive on some of that.
Well, thank you, Dave. Yes, please, Denise, let us know if you have further questions. I do see a question came in from Joe. Are they getting rid of submission by claims?
I
They
can actually
haven't?
do that. I have something pulled up that I actually just sent to another clinic that is, they don't have an EHR. So let me know if you guys can see this. Can you see the Excel spreadsheet?
Yes, we can.
Okay. So what this is this is actually a clip of just the claims, Part B claims measures that have benchmarks. So this is from the 2021 quality, measure benchmark list. And I pulled out just the claims measures for a clinic so they can see what they're looking at for points wise. So as I did mention, they removed 11 quality measures from the group for 2021, and 8 of those were, 13 measures and 11, I think, were claims-based measures. So that makes it that much harder for somebody to report successfully with claims, especially since we're going to get away from the neutral score, and the score is going to basically be, a 50-50 of what everybody reports. So it'll be 50 above and 50 below. But if you look at this information, so here are the measures that you can report via claims, which the list is a lot shorter than what other method types are. But the important thing to look at is over here. So if you see these deciles, this is how you're scored, like how many points you get per measure. So if we look at age-related, what's this one, measure 14 here. As you can tell, even if you get 100 points, you only get 3 points, and there's quite a few of them. If you look down here where they're maxed out at a certain point level, and there's only a few that actually go all the way to the 10-point mark. If you look through and look at all this data. So to successfully be able to report, via claims, it is very difficult to be able to get, the amount of claims or quality measure points that you need to push yourself up into that upper echelon of the point scoring. So they're just making it more and more difficult for claims submissions. Now, are they going to do away with them? We have not heard anything like that, but I can tell you that it's getting harder and harder for people who report via claims to reach that neutral benchmark.
That was a great visual. Thank you, Miranda, because we talked about topped out measures earlier, but we didn't talk about the benchmark on measures. And as you can clearly see from this visual, there's a lot of claims measures here that will not get you full points, even if you do a fantastic job on reporting them. So they're not getting not exactly getting rid of them, but they're, like Miranda said, not making it easy for you to get a good score with claims. So they're kind of pushing everybody to get them into, health IT. They want this back and forth via electronics. And I mean, that's really what promoting interoperability is about. I know when we had registration, we had some promoting interoperability questions. Maybe now would be a good time to address some of those. Jeff, do you want to talk to us about the promoting interoperability measures?
Sure. Can you be a little more specific? I mean,
Yeah. Well, let's start with the security risk analysis. We know.
Sure.
Go ahead.
Yeah, that is it's not a point. It's not it doesn't account for any points, but it has to be done, and if it's not done, you'll fail the entire program. So it's generally it's a yes no, and you need to do the SRA, and you have some tools to do that. On the website, the CMS's site has a tool that you can use. It gives you sort of an outline to go through it. What that does is help you create your mitigation plan. So you don't submit any documentation when you submit for the SRA when in the reporting period. It's just a yes no, but you have to have documented whatever mitigation plan to correct or fix any problems that you find. So and you have to have a 2015 cert. So I can send any, let's see, actually I will, if anybody's interested, I'll put that in chat. It's to get the tool. And again, you just use that as an outline to conduct the analysis.
Thank you, Jeff. I think that would be great.
Can I add something, London?
Yeah, Aaron, I was just about to ask you. I saw there's another question, referral loops, exclamation point. So please add to and then continue on.
So for the security risk, one of the things I hear frequently is, oh, my IT people do that.
All right.
That is not a safe assumption. And so when Jeff mentioned, the records and documentation that's required, if your IT people do that, make sure that you keep that documentation that they're going through what qualifies as a security risk analysis. Other thing too about closing the referral loop, that can be a very difficult one to do. And so what I do with the clinics that I work with, if it's a primary care physician office, I say, who do you send the majority of your referrals to? And usually it's either like a cardiologist or an orthopedist. And so then I ask them to contact them to see if you can get connected to close the referral loop. And so by focusing on where the majority of the referrals lie, the goal is that you can start closing some of those referral loops. You're not going to get to 100%, but it's a good start. And so if you were to call, that cardiologist that you're working well with and tell them that what you're doing for Mips, odds are they're also trying to work on Mips as well. And so trying to work on some of those similarities with the network that your patients get care in is how I try to set my physician offices up with.
Well, there's another option for you as well. If referral loops are really where you're struggling with your promoting interoperability measures, remember promoting interoperability is a 90-day window. If you can find a 90-day window where you have less than 100 referrals, you can exclude out of that measure.
And I would also add this, if this category is your biggest headache and you qualify for the hardship exemption, apply for that hardship exemption. That came out earlier this week. The application process is very easy to do, but just be mindful that that category will be rated to 0, and all of the promoting interoperability points will get reweighted to the quality category. And so you're going to need to make sure that you're on point in your quality category, because that takes a lot more of the Mips score than it previously did.
So I want to build a little bit on what Aaron just said there. So it is important to remember as well when it comes to reporting. So when you fill out and you get that promoting interoperability hardship exception, you were approved for it, you want to save that documentation, because it's always better to have a trail of paper, or saved, images than to just say, yeah, I got an email, I can't find it. But what you want to make sure is if you are an EHR reporter and you report like with the QRDA3, you need to be speaking with, if you generate your own QRDA3, or if, the company actually does it for you and then sends you the file, you want to communicate with them that you actually have that PI exception and that they shouldn't pull that data for you. Because if they put any of that data into your, file that you then report with, that will override your exception, and you'll have to take whatever points you actually get. So the important thing is, fill out and get the application, and to make sure you got the documentation that you're approved, and then to confirm that when you're reporting that you're not putting any data, not a time frame, not anything. Don't put any data into that section for the reporting, to make sure that you don't end up nullifying your PI exception.
It looks like we got another question from Heather. Let's see. Oh, and I just lost it. Sorry about that.
I have it. Do you consume CCDA via an HIE or direct messaging? If HIE, you get multiple CCDAs that you must reconcile.
Sharon, were you going to answer that question? I'm sorry, I saw you come off video or on video.
I can certainly try. This may depend on your HIE, and it may depend on whether you have like a push or a pull system set up. So let me explain that a little bit. A pull system would be, I am admitted to your emergency room, and you are able to, within your system, say, okay, Sharon Phelps just came into the emergency room, go out to the HIE and pull in all the data you have, or the latest CCDA you have on Sharon. And then it would pull in that specific, it would match me to Sharon Phelps in the HIE, and then it would pull in whatever data is there for me, and you could reconcile that for me. That's what I would call a pull system, where you are querying the HIE. A push system would be where whenever a patient is seen elsewhere that has you listed as a primary care provider or a specialty provider, or somehow your hospital, your provider, whomever is indicated on that record, it goes to the HIE, and that HIE says, hey, they belong to your clinic, and it pushes that data to you. You would then get a queue where every time somebody else saw your patient and they were hooked up to the HIE, that it would push you that information, and you would have to reconcile that. So I would actually encourage you to ask that question of your EHR vendor to kind of understand how you're configured with your HIE. And it may have to do what your state HIE is capable of doing as well, because different HIEs are configured differently and have different capabilities. Does that help?
Thank you, Sharon. I think that was a good answer. I see that we are, wow, nearing the top of the hour, and I want to make sure that we got all of the questions that you brought with you today answered. Please type into chat any last minute questions that we can answer for you while we're all gathered. I see, Joe, you were asking about the feedback reports. Those do typically come out in July, so look for those. And like we mentioned earlier, we're not certain about cost feedback, if you'll be seeing that or not. Thank you, Miranda. Once again, here's how you can contact your specific quality improvement advisor, your Mips expert in your state. Please feel free to reach out to them with any questions you have. I'm not seeing any new questions come into chat.
London, is this webinar going to have a survey afterwards?
I do not have a survey for our webinar today, no.
Okay, just wanted to confirm.
Mm-hmm.
And then, I'm not sure, this wasn't really a poll question, but if you guys found this valuable, as opposed to having to sit through an entire webinar on a specific topic that we pick, is this format of where, you guys kind of preload questions to us or ask them in real time, is this more beneficial for you where you can get your questions answered directly? Or would you prefer, the more specific, topic that we choose at the time? So if you can kind of put that in chat, if you like the open office hours, or if you, don't think it's just let us know.
So far, we're getting positive feedback that this is working. So we love having that interaction with you as an audience and getting directly to your questions instead of us just pushing information out to you. So awesome. Thank you so much for attending today. And great. Thank you, Heather, for allowing us to share your comments. Well, not seeing any more questions coming in. Was there anybody on the panel that had any last parting thoughts for our audience before we end?
Nope, all good here.
I would just say, if you have any questions or have any needs whatsoever, just contact your consultant and they'd be happy to help.
Yep, very true. Thank you, Perrin. Well, everybody, thank you so much for joining us. I hope you have a great rest of your day, and we will be talking to you all soon.